Hello, I am Martin Lederman, co-founder of the organization One World, One Vision. Over a decade ago, my associate and I, while on a surgical mission to Belize, founded One World, One Vision in order to train local ophthalmologists and, by doing this, extend our reach. We were successful, and since then, our organization has gone to multiple countries and have demonstrated the success of our ideas. We added anesthesiologists and pediatric intensivists to the mission in order to train local physicians and make the surgical experience of our patients safer. Since then, we have realized that the paradigm of one patient, one student, and one surgeon, while successful, could not begin to address the need. There are tens of millions of children and adults with strabismus and amblyopia. We decided, therefore, to support and to promote a video course in strabismus and amblyopia and approached Dr. Bert Kushner to develop a curriculum and to recruit worldwide experts to give lectures. We stipulated that the course should be translated into multiple languages and to be distributed without cost around the world to eye surgeons. We are particularly grateful to our former patients and friends who have given the financial support to make our dream a reality. We are delighted that Dr. Kushner has accepted the challenge, and we hope you find the lectures both stimulating and educational, and that you share them with your colleagues and your students. And so, without further ado, I give you Dr. Bert Kushner.
Welcome to this One World, One Vision comprehensive course on strabismus and today's lecture on torsion. If you're new to this series, I'm glad you're trying it out. If you're a former viewer, welcome back. We are particularly fortunate today to have Dr. Stacy Pineles as our lecturer. Dr. Pineles is a professor at the UCLA Stein Eye Institute, where she is also the residency program director. Recently, she has been appointed as chair-elect of PEDIG, the consortium of over 100 sites that does collaborative trials in pediatric ophthalmology and strabismus. And the fact that she was appointed to this position speaks volumes about the high opinion her colleagues have for her intellect and her scientific rigor. I consider Dr. Pineles to be one of the brightest stars in our field. She has keen insight, is a practical and innovative clinician, and when Dr. Pineles speaks, people listen. And that's exactly what you're going to get a chance to do as I turn the podium over to Dr. Stacy Pineles.
Thank you so much, Dr. Kushner. I really appreciate the opportunity to be here. So today I'll be speaking about torsion as part of the One World, One Vision comprehensive course on strabismus. Let's first define torsional strabismus. Torsional strabismus occurs when the eye is rotated abnormally about the visual axis. So intorsion is when the 12 o'clock clock hour is rotated nasally, and extorsion is when the 12 o'clock clock hour is rotated temporally. You can see how the fundus images would look here in these pictures. There are two important definitions when we talk about torsion. One is objective or anatomic torsion, and the other is subjective torsion. So let's look at those two terms. Objective or anatomic torsion is when there's an observable rotation around the visual axis. You, as the examiner, will look at the fundus and see that there's actual rotation. This can also be seen on imaging such as MRI. Subjective torsion is when the patient perceives rotation of the visual axis. They say that an image that they're seeing from that eye is rotated. This may or may not be associated with objective torsion, and it's very important to differentiate in your mind as the doctor whether or not the patient has objective and or subjective torsion. There's torsional position and torsional movement as well. The torsional position of the eye refers to the torsional position at rest. So if a patient is sitting, looking at you, and they see one of the images tilted, or if you're sitting looking at them and you see their fundus torted, then that's their torsional position. An example would be a patient with a superior oblique palsy who has a constant resting state of excyclotorsion. Torsional movements are abnormal torsional rotations during eye movements. An example of this would be a dissociated vertical deviation. The patient may not have torsion in resting position, but when the DVD occurs, the eye rotates or torts. And so a torsional movement is different than the resting torsional position. And these are just some terms that are important to understand as we move on through this lecture. When we talk about anatomic torsion, we need to have a way or a rubric in order to measure it. It's difficult to measure torsion, but we can do it in one way by comparing the relative position of the optic nerve and the fovea. If one were to draw a horizontal line from the fovea to the optic nerve, it should intersect within the inferior 1/3 of the nerve. So if you're looking with an indirect ophthalmoscope where everything is inverted, you'll see here that the X in this picture defines the fovea, and a straight line from that position should intersect the bottom 1/3, or in the indirect, the top 1/3 of the optic nerve. And then every point towards extorsion or intorsion is +1, +2, +3, or +4. This is difficult to assess in a person just by looking, but it can be done a little bit easier using fundus photography. When we talk about subjective torsion, so we're not just looking at the fundus and measuring it, we're asking what the patient sees, there are several tests that can be used. The least dissociative test is the Bagolini lens, and there's a figure here showing what it looks like. Bagolini lenses are clear lenses with an etching that produces a streak of light opposite to where the etch mark is. So in order to do this test, you're going to orient the streak at either 90 or 180 degrees, so they should be straight, either horizontal or vertical lines. And then you're going to ask the patient to rotate the streaks until they're superimposed. If the patient has horizontal or vertical strabismus, sometimes you need to put a prism up in order to allow the two lines to be overlapping from a horizontal and vertical axis. If the patient needs to rotate one of the lenses in order to superimpose it on the other, that means they have subjective torsion. A slightly more dissociating test is the double Maddox rod. This test uses Maddox rods, which are lenses that are shown here in this picture, that allow a patient to see a streak of light when a light is shined on the lenses. So 2 Maddox rods, or double Maddox rods, are placed in front of the patient's eyes in a vertical orientation, which will allow the patient to see horizontal lines from each side. You may need to use prism to superimpose the lines again, and then similar to the Bagolini lens test, the patient is asked to rotate the lens until it's parallel or superimposed with the straight line. We use 2 different color lines so the patients can describe red and green or red and white, and sometimes because of this, the torsion localizes to the incorrect eye. Frequently, they localize the torsion to the red lens. So it's nice to do that test twice, one with the red lens over the right eye, and then once with the red lens over the left eye. Here's an example of what a patient might see with double Maddox rods. With the right eye that has the red lens, they'll see the line tilted in this direction for excyclotorsion and the opposite for encyclotorsion, and similar for the green lens for the left eye. So if they see one line that's horizontal and one line that's tilted, they tell you which color it is, and you ask them to rotate that line. And then on the lens trial frame holder, you can measure the amount of torsion. That's subjective torsion. The Lancaster red-green test takes more technical expertise. This is a diagram of horizontal, vertical, and torsional deviations in 9 gaze positions. You have to have good vision in both eyes to do this test, and it requires a technician to shine a light in each of the 9 positions of gaze, and then the patient lines a second light up with the technician's line. And you can see from the example here on the lower right corner of the slide that this patient had a torsional horizontal deviation that was worse in down gaze. Lastly, the synoptophore is another test that requires equipment and expertise, but patients are asked to look into the synoptophore with each eye viewing one of these tubes, and slides are utilized to place into each side, and patients are asked to fuse the image. So in this example I've shown here, there's a house that has a yellow bird on one side and then a red bird on the left side. If a patient fuses it, they see the house with the two birds. However, if they have torsional diplopia, they may see the images superimposed with some torsion. And so the synoptophore can be used similar to a prism in horizontal and vertical deviations. The synoptophore can be used to induce a torsional correction until the patient can fuse. And that's a really nice way to measure subjective torsion. In terms of objective or anatomic torsion, we talked a little bit about fundus photography and indirect ophthalmoscopy. Remember that for indirect ophthalmoscopy, the images are inverted. A line through the fovea will pass through the superior one-third of the disc in indirect ophthalmoscopy. And David Guyton published a grading system that some people used in order to quantify the torsion. This is a figure from earlier in this talk of the right fundus using the indirect view. You can see the X is placed at the fovea. A line through that X to the optic nerve intersects with the superior one-third of the optic nerve in the indirect view. And then each 1/8 disc diameter from that position, from that one-third, superior one-third, is another plus of torsion. So if you're 1/8 disc diopter above the superior aspect of the optic nerve in the indirect view, that's +1 x torsion. This kind of measuring and grading is easier in my mind on fundus photos, especially with young children and even adults. It's hard to sort of measure out 1/8 disc diameter in a live person whose eyes are moving. As I mentioned earlier, MRI can also be used for objective anatomic torsion. Quasi-coronal imaging is best in order to look at the position of the rectus muscles. And you can see here, both of these orbits are extorted. Let's move on to talk about some etiologies of torsion. I have listed some of the most common etiologies of torsion. These include cyclovertical childhood strabismus, extraocular muscle disorders, neurologic disorders, and disorders of the orbit. Extraocular muscle paresis can cause torsion. All three types of cranial nerve palsies can cause torsion. In a cranial nerve 3 palsy, the most common finding is intorsion or extorsion. It depends on which muscles are involved. If you have an inferior division third nerve palsy, frequently you have involvement of just the inferior oblique and inferior rectus, and in that case, you would have intorsion. However, if you have a superior division third nerve palsy, it's possible to have extorsion if you have a superior rectus paresis. So torsion in a third nerve palsy is really related to which division or how much each muscle is affected. The classic torsion from a cranial nerve palsy is a cranial nerve 4 palsy. We know that the superior oblique muscle is an intorter, and so patients with superior oblique palsies have extorsion. Usually, if it's a unilateral palsy, they have about 10 degrees or less of extorsion. If a patient has more than 10 degrees, then you want to start to think about whether this could be a bilateral palsy. The torsion is frequently worse in down gaze. And fourth nerve palsies are sometimes confused with skew deviations, and torsion isn't always helpful because skew deviations can cause torsion, either extorsion or intorsion. Now let's talk about restrictive strabismus. Some of the causes of restrictive strabismus that can be associated with torsion are listed here. Thyroid eye disease frequently affects the inferior rectus, so the most common type of torsion in that condition is extorsion. Brown syndrome has a tight superior oblique. Frequently, these patients don't have much torsion in primary position, but when they try to look up gaze, they have intorsion. Then ocular surgery can also be associated with complications that cause torsion. When patients have retrobulbar anesthesia, there can be local myotoxicity, especially to the inferior rectus, which can cause weakness or tightness, and that will cause torsion either in cyclo or ex cyclo torsion. And finally, ocular surgery like scleral buckles and glaucoma valves can cause torsion in either direction, depending on which muscles are scarred or tight from that procedure. In terms of trauma, the most common cause of ocular orbital trauma to cause torsion is an orbital blowout fracture, most frequently causing a tight inferior rectus from entrapment, which causes X-torsion. In addition, you can have congenital ocular torsion from anatomic abnormalities such as craniofacial syndromes. Most commonly, craniofacial syndromes and craniosynostosis are associated with X-torsion, or orbital bands or missing muscles or other anomalies that create torsion. Similarly, there can be displacement of the trochlea from orbital malformations, and that can cause torsion as well, depending on how the trochlea is misplaced. When should torsion be treated? We talked a lot about how to measure it and what can cause it. The main indication for actually treating torsion is when the patient perceives subjective torsion. If I look at the fundus of a patient and see objective torsion, but the patient sees single, then there's no reason to treat that. However, if a patient has subjective torsion, they start to see double from that, usually when it's more than about 7 degrees, and that condition should be treated. It may also be appropriate to treat torsion as part of a plan to address a motility pattern if you're concerned that the treatment that you're going to do will worsen the torsion that's already there, and then the patient may be at risk for subjective torsion. So if a patient doesn't have torsional double vision, but you're doing surgery that might induce more torsion in the direction that they already have, then that's another reason to treat torsion. It's important before doing surgery on these patients to use the synoptophore and make sure that the patient can actually fuse. We don't want to promise or tell a patient that they're going to see single after a surgery if there's fusion disruption that would preclude the benefit of treating their subjective torsion. Lastly, I want to talk about how we treat torsion. The first step in torsion treatment and surgery is to do force duction testing. We know that when we do force duction testing on the rectus muscles, we should do that first, and we typically proptose the globe in order to put the muscles on stretch. However, when we do oblique muscle force duction testing, we actually want to retropulse the globe a little bit to put some exaggerated traction on the oblique muscles. There is going to be a video in another lecture called Reoperation Strategies and also Vertical Strabismus that will show you how to do this test. But in brief, you want to retroplace the globe and then rotate it. For the superior oblique, you're going to grasp the nasal conjunctiva and rotate the eye nasally and then supranasally to feel for a bump from a tight superior oblique. For the inferior oblique, you're going to grasp the eye inferiorly and move it from infranasally to temporally. Let's talk about 3 different surgeries that one can do on the superior oblique in order to address torsion. The first one is the superior oblique tuck. This is useful for patients with severe superior oblique underaction, including vertical and torsional abnormalities. It's especially useful in patients whose deviations are worse in down and ipsilateral gaze. It can correct up to 12 degrees of torsion and 15 prism diopters of vertical deviation. I have a photo here in the lower right corner, which shows a superior oblique tuck. The superior rectus is labeled, and the superior oblique has already been tucked with 2 sutures holding the sides. And then the forceps are holding the sort of folded over or tucked superior oblique. When we do this type of surgery, it's very important to put the sutures on a temporary knot until you can repeat the force duction and get it into a position that you think is going to be good for the patient. You never want to tie the sutures down permanently on the first tuck that you do because it may not be strong enough or it may be too strong. An alternative to a full superior oblique tuck is to resect the superior oblique at its insertion. The downside to this procedure is it does tend to unwind, but it's less likely to be as strong as a tuck and cause an iatrogenic Brown syndrome. I want to move on now to the Harada-Ito, which is useful in patients with X-torsion, but who have little vertical strabismus. So unlike the tuck, which corrects both torsion and vertical deviation and is a very powerful surgery, the Harada-Ito can be more forgiving because it only works on the torsional fibers of the muscle. Remember that the anterior fibers of the superior oblique are the torsional fibers, and the posterior fibers are the ones that act vertically. So this surgery consists of separating the anterior from the posterior fibers and then moving the anterior fibers forward towards the lateral rectus in order to cause the eye to intort. And it can correct up to about 10 degrees of torsion, but it does tend to unwind, and so overcorrection initially is recommended. Here's a photo of a finished Harada-Ito. You can see the superior oblique anterior fibers here labeled SO, and they're sutured about 8 millimeters posterior to the border of the lateral rectus. One cool thing that you can do with the Harada-Ito is use the position that you place the superior oblique to correct small amounts of vertical deviation. So if you move the superior oblique towards the lateral rectus, but also anteriorly, that might cause the superior oblique to give up a little bit of its depressing action from those fibers and pull the eye up a bit. So you can move it anteriorly if you have a small hypotropia, but the main purpose of it is to treat torsion. One alternative to a Harada-Ito that we're doing a little bit more here at UCLA is what we're calling a modified anterior superior oblique tuck, where you divide the fibers just like you do with the Harada-Ito. You can see that happening on the top panel here, the top 3 pictures. And then you do a tuck just on the anterior fibers. So it's a combination of a superior oblique tuck and a Harada-Ito, where the tuck is only done on the anterior fibers. The nice thing about this procedure is you don't have to place sutures so far back on the lateral rectus muscles, which can be a little bit dangerous in that thin sclera. I'm going to move on to talk about 2 procedures for superior oblique weakening. This is when the superior oblique is too tight and patients have intorsion. The first is the superior oblique anterior tenectomy, which is useful in cases of intorsion without a vertical deviation. So kind of like a Harada-Ito, but in the opposite direction. Here, you're going to split the superior oblique into anterior and posterior fibers. And instead of advancing them to the lateral rectus like you do in a Harada-Ito, instead you're going to remove those fibers and just leave the vertical acting fibers intact. So this is a pretty safe and easy surgery to do. And if you remove those torsional fibers, you can correct up to 5 to 6 degrees of intorsion. A superior oblique spacer is a much more powerful procedure with a lot more risk. Its cousin in the other world is superior oblique tuck. The superior oblique spacer is used when the intorsion is accompanied by a vertical deviation. And what you do is you use some kind of material, either suture, a silicone band, or other material that can be sutured between severed aspects of the superior oblique to lengthen the tendon. And this again is done using adjustable sutures while the patient is under sedation so that you can repeat the force duction until you're happy with the result. So those are the 5 types of superior oblique surgery we do for torsion. I'm going to move on now to inferior oblique surgeries, which are inferior oblique recession, myectomy, and transposition. Inferior oblique recessions and myectomies are indicated for X-torsion and hypertropia. Some surgeons use a graded recession so that you can quantify how far back you're putting the inferior oblique, keep track of what you've done, and also keep track of the muscle in case you need to go back to it. This figure here and table next to it show how we can quantify the amount of inferior oblique recession that we're doing based on measurements from the inferior rectus muscle. Other surgeons will just do a myectomy where they disinsert and cut the inferior oblique muscle out. And this is also used reliably by many surgeons. The downside to that procedure is not really being able to go back to it if you need to undo it. An inferior oblique anterior transposition can also be done for larger deviations. Instead of recessing the inferior oblique back along that path, which is measured from the inferior rectus, The inferior oblique is instead sutured more anteriorly, closer to or even in front of the inferior rectus insertion. This is useful for larger deviations. It's a more powerful surgery, but there is a higher risk of anti-elevation syndrome. Another type of inferior oblique transposition that's gaining popularity is a nasal transposition, which converts the inferior oblique to an intorter and anti-elevator. It corrects large amounts of extorsion and vertical deviation, especially in upgaze. The concern with this procedure is anti-elevation syndrome. I want to also mention rectus muscle offsets. You can transpose the horizontal or vertical muscles in order to account for torsion. An example would be if you transpose the inferior rectus nasally, a full tendon width, that can correct 7 degrees of extorsion, especially extorsion and downgraze. If you move the superior rectus temporally, that gives you even more correction. Horizontal rectus muscle transposition can also be done in a similar manner, but in my hands, it's less effective than the verticals. It's important to remember that rectus muscle transposition for torsion often works against a coexisting pattern. So for example, a nasal transposition of the inferior rectus for extorsion in a bilateral superior oblique palsy will worsen the V pattern that those patients frequently present with. So in conclusion, torsion can be anatomic and subjective. When you have subjective torsion, that can be treated with surgery. The surgeries we talked about are superior oblique tucks and similar surgeries, which address the vertical and torsion deviation, and then Hirata Itos and alternatives, which just affect the torsional deviation. Finally, there's inferior oblique weakening procedures, which tend to address extorsion. And with that, I'd like to thank you, One World, One Vision, for putting together this seminar and for inviting me to speak on torsion. Thank you so much.
Thank you, Dr. Pineles. That was wonderful. I do have just one question. When you talked about different techniques of weakening the superior oblique, do you have any experience with or thoughts about the role and the hierarchy of power of the split tendon lengthening procedure of the superior oblique? Is it comparable to a spacer, more powerful, less powerful, pros and cons? Any thoughts?
I don't have a lot of experience, so I want to hear your thoughts, but I would say, just based on anecdotes, I would say it's frequently less powerful than a spacer, but it does more than just, an anterior tenectomy. I haven't used that procedure. Some of my colleagues at my site use it a little bit because of the lack of scarring that you worry about with superior oblique spacers. But in the patients I've seen, it hasn't been as strong. Maybe there haven't been enough cuts done. What about you, Dr. Kushner?
Well, it is my preferred technique if I want a major weakening of the superior oblique. I found it comparable in power to the spacer, and the advantage is mainly just that I'm not putting a foreign body in that area. You are putting sutures in there, but they're further up toward the trochlea than the temporal most suture on a spacer, which is right near the superior rectus and hence up against the sclera. So that's just by my own bias. Well, again, I'd like to thank you for a wonderful talk, and viewers, thank you all for tuning in. And if you found this helpful, I hope you'll tune in to the other lectures in this series. And with that, I wish you all a good day, good morning, good evening, good afternoon, depending what part of the world you're tuning in from.
In bringing you this video course, there are many thank yous. Thank you for viewing the video course on strabismus. We hope you found it stimulating and educational, and that you share its insight with others. We at One World, One Vision extend our heartfelt thanks to the lecturers who shared their years of study to make the video course worthwhile. And of course, to Bert Kushner for taking on the burden, happily we hope, of development and moderating. We also thank the Board of Directors for their continued guidance. We thank our donors for their financial support that made this video course possible. An enormous thank you to the video team of Sweet Sadie for their extraordinary efforts to make the course, both visually and auditorially, extraordinary, and for their technical guidance of lecturers. Thank you, Rachel, Tim, Eddie, and Bill. If you are interested in learning more about what we do, go to our website, www.oneworldonevision.org. And finally, if you have comments or thoughts or ideas, you can email me at owov2020@gmail.com. Goodbye.